manage that.
Okay.
Okay, we are live now. So I'll do countdown and then hand over to Dr. Mallikarjun for IACP webinar 4. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Today is Saturday 4th, and soon we are going to start IACP webinar 4. I invite President of IACP, Dr. Mallikarjun, to start the proceedings and introduce the webinar. Thanks.
Good afternoon. On behalf of all Board of Directors and EB members, we welcome all of you to IACP webinar 4, organized in association with the CRC Ranchi. And I'm also very happy to inform you that each webinar organized by IACP is very effective. Over 1,500 participants attended and viewed the webinars. They all appreciated and they requested us to continue this series of webinars. And for this, I really thank all of our Board of Directors and EB members, especially my technical team, Dr. Asha, Dr. Sanket and Madhavi, and Dr. Meenakshi Tharalnagda for their continuous support for making this all webinars successful. And this is today's webinar is a one we have a wonderful teacher and researcher, Professor Emin Christine Eames, with us to disseminate her expertise on goal-directed intervention focusing on participation outcomes. And along with her, we have our board of director and our mentor, Dr. Shashikala Madam, to bless this webinar. To moderate this webinar, we have today reputed professionals, Dr. Sunanda K. Reddy. She is a developmental pediatrics and researcher and wonderful person. She is a lot of experience, done a wonderful work in the field of community-based rehabilitation, and she is going to moderate this webinar. Along with her, we have a very popular occupational therapist in India, Dr. Anjali Joshi. Her program, her teaching on PayPal is very popular in our country, and she is a wonderful teacher and researcher in the field of occupational therapy in India. And I welcome all of you, and we are going to have a feast on a goal-directed intervention focusing on participation outcomes by Professor Christina Eames. I thank her within very short notice. She accepted our invitation and she has shown a lot of affection towards Indian Academy of Cerebral Palsy. She spared her valuable time to record her lecture and share presentation well in advance, and I thank her. Now I request Dr. Meenakshi Girish, Asha Chetnis, to introduce our Dr. Shashikala Madam to bless this webinar. Over to Dr. Asha Chetnis.
Sure, sir. Thank you, sir. Good afternoon, everybody. Hope all are doing well. It's a proud privilege and an honor for me to introduce one of our past presidents and board of directors, Shashikala Madam, who is a developmental pediatrician and works in Bangalore at the Sagar hospitals. She has 28 years of experience. She's a role model, a mentor, and a resource person. She's also a founder of the IDEA module, a role model as a mother of child with cerebral palsy. She was awarded honor by the the Persons of Disability Day, on Persons of Disability Day, and Madam has yet not joined, so we seek her blessings in absentia. And then I request the madam to introduce two of our moderators. Enjoy this.
So Dr. Meenakshi will introduce both the moderators of the session.
Thank you very much, Taral. It is my privilege to introduce Dr. Sunanda Kohli Reddy, who I'm proud to say happens to be a friend of mine. She is a developmental pediatrician trained in Canada under Dr. Peter Rosenbaum. Her special interest is in early intervention for children with neurodevelopmental problems. Dr. Sunanda is based in New Delhi and is utilizing her expertise, which is immense, I should say, at grassroots level through community-based rehabilitation program. Dr. Sunanda is director of an organization called Care Nidhi, and she has been part of several community-based research in the field of child development. I welcome you, Dr. Sunanda, as moderator for this webinar. I would also like to introduce Dr. Anjali Joshi. It's a privilege to read out her CV. Dr. Anjali Joshi is an occupational therapist and ex-associate professor in a reputed institute in Mumbai. Now she provides services as a consultant to several national and international parent and professional groups. Her academic credentials are highlighted by her presence in the editorial board of a journal, the Annals of International Occupational Therapy. Currently, she is project director and lead faculty for a very interesting training program in India, the PlayPal. Welcome, Dr. Anjali, as the second moderator for this webinar. I request
Thank you.
Dr. Sunanda to introduce our guest speaker for today.
I'm also the Apex Strategy facility at the University of Melbourne. I wonder if Sunanda was on mute while she was speaking. Okay, are you ready for my
I think so. I'll
presentation?
introduce you.
Thank you. Thank you, Asha.
Most welcome. I think so. It's another privilege, honor for me to introduce Professor Christine, who's an Apex Chair at Neurodevelopmental and Disability from Australia. She's an occupational therapist and she has immense research behind her. She comes from the Department of Pediatrics, University of Melbourne. And I tell you, today it's going to be a day to hear her presentation on participation. It's just going to be interesting, and I hope it opens new vistas, new ideas for all young and practicing pediatric therapists all around the world. Enjoy her. Thank you so much for joining us, Professor Christine.
Thank you. Thank you so much for the invitation and the very warm welcome. Is it possible that I could have the screen now so that I can, thank you, so I can screen share? That would be excellent.
As Christine is sharing a screen, it's our pleasure to invite Dr. Ashok Johri and Dr. Medani Padhe. Dr. Ashok Johri is a pediatric orthopedic surgeon and past president and founder member of IACP. Dr. Medani Padhe is a very senior occupational therapist, and we are very happy both of them are here. Christine, please start.
Thank you so much. And once again, thank you for the invitation. It was my absolute pleasure to accept, and it's an honour to be able to present on some of the work that we have been doing. I need to start my presentation by saying that I am very aware that I have no real knowledge of the culture and situations in which you're working in India. And that means that you will have to do the thinking about how to use the information and ways of thinking that I'm sharing with you today. And also to think about the particular challenges and opportunities that might be in your own settings and situations that will help you use this knowledge and way of thinking. So I look forward to our discussion at the end. My plan today in this session is to talk about what I mean by participation and about being goal-directed when participation focused, to talk about some of the evidence about goal-directed interventions to improve participation and the key ingredients for those interventions. But first, let's think about some of the children and young people with cerebral palsy that we work with. George is 11 months old. He has spastic quadriplegia. His gross motor function level is 4, and he's too young to classify on the Minimax. He's a socially engaged little boy who's generally happy. His play is limited by his movement disorder, but he loves his food and he wants to feed himself. Alice is 2.5. She has GMFCS 3 and Minimax level 2. Alice loves to walk pushing a trolley with her toys in it, but this is difficult for her. Alice is showing interest in taking off her clothes and helping with dressing. Ursula is 5. She's classified at GMFCS level 2, Max level 2, and communication function level 1. She's shy. She enjoys playing with her sisters, though. Her family are recent refugees and have experienced significant hardship over the past few years. Ursula will start school next year. Melanie's 12. She has GMFCS level 2, Max level 2, and communication function level 2. She lives in a regional town, attends high school, and loves her dog and the farm horses. Morris is 18. He has GMFCS level 4, Max level 4, communication function level 3. He's nonverbal. He loves reading the newspaper, cruising around the shopping centre, and his sports. Karen's 29. She has GMFCS level 1, Max level 2, CFCS level 3. She has a university degree and is working part-time in a paralegal role. She has struggled to maintain friendships and she has some mental health concerns. People who have cerebral palsy are really diverse in their presentations of their condition, their ages, their living situations. And for each of the simple examples I've just given you, participation is critical. It's the primary thing they do all day, every day, in a variety of ways and with varying success. But what do I mean by participation? In 2001, the World Health Organization published the ICF, the International Classification of Functioning Disability and Health, and along with the framework shown in this slide. The framework describes functioning and/or disability as outcomes of a dynamic interaction among the health condition, body functions and structures, activity performance, participation, and contextual factors in the environment and the person. In the ICF, participation is defined as the nature and extent of involvement in a life situation, or if there's a problem, it's called a restriction of participation. The publication of the ICF was really positive. It's strengths-based in its language and its conceptualization, and it's provided a very good framework for research and for practice. Since publication of the ICF in 2001, I, along with many other people, have been researching participation. And my research history in the area includes longitudinal studies, qualitative research to understand the experience of participation, pilot intervention research, and systematic reviews of current evidence. But since 2001, research has been able to map participation patterns, barriers, and facilitators, and there's been some emergent work in intervention research. But I would also say that since 2001, there was a lot of discussion about the difference between activity and participation. And the problem was that there was no clear distinction between the two ideas, activity and participation, in the ICF classification system. In an effort to address the various approaches of understanding participation, we undertook a systematic review of effective interventions that aim to improve participation outcomes for children with disabilities. Our rationale were twofold. Is it okay?
We can hear
Is
you.
everything okay?
Yes, yes, it is okay.
Okay, everything's okay. Sorry, I thought someone was speaking. Okay. So in an effort to address these different issues related to the differences between activity and participation, we undertook this systematic review of the effective interventions that aim to improve participation outcomes for children with disabilities. Our rationale were twofold. We wanted to know what worked, and we thought that researchers that designed intervention studies that aimed to change participation outcomes would have clearly defined their outcomes and carefully chosen their measures. What we found was 7 randomized controlled trials that included participation outcomes. But what we also found was that there was little evidence of effectiveness of interventions that focused on fixing body structures and functions or building specific skills that did not have an effect on participation. We also found that there was no consistency in how participation was defined in these different studies. So then we thought we would learn more about the idea of participation by looking at all of the intervention research, not just the randomized trials. So we did a systematic review of language, definitions and constructs used in intervention research with children with disabilities, and this included 28 studies. And from this review, we derived a definition of participation, and we identified that there appeared to be a family of participation-related constructs. That is, elements that were important for participation, but were not the same as participation. Following that second review, we did a more conceptual review to seek evidence in support of the family of participation-related constructs. And as a result, we refined the family of participation-related constructs and described participation as a means, that is a process, and an ends, or an outcome. So following that empirical work, we defined participation as involvement in a life situation consistent with the World Health Organization, but we also described it as having 2 essential elements, attendance and involvement. And attendance is defined as being there, that is, being able to be in the situation. So we might think about that as how often you attend something or the range or diversity of activities in which someone takes part. And involvement, which was defined as the experience of participating while attending. And that could include elements of engagement, persistence, perhaps social connection and affect. So it's possible that you are familiar with the family of participation-related constructs diagram, but I think it's important to build the picture for everyone, because in doing so, I can clarify the language, the definitions, and the intent of the framework's constructs and relationships. This is important because understanding these elements can help us to think about how to intervene to promote participation. So we start with the environment. All participation is situated within an environment defined as the broad, objective, physical and social structures in which we live. The environment, however, also has a perceived or subjective element described by Maxwell and colleagues as the sense to which it is experienced as available, accessible, affordable in terms of your effort and time and energy, accommodating, and the extent to which any accommodations are acceptable to both the individual and others in the environment. When we think about the 2 dimensions of participation, it's likely that the extent to which the environments are available and accessible and affordable influences attendance, and the accommodations and acceptability of them probably influences involvement. Within our broad environments, though, we actually operate within closer contexts, and using Beata Bitorowicz's work, we describe the close context for activity as being constructed of place, people, objects, activity, and time in which the participation occurs. So now we put in participation, which I have already said is comprised of two elements: attendance, defined as being there, and involvement, defined as the experience while attending, which might comprise of engagement, persistence, affect, and perhaps social connection. But I would say you can participate in something all by yourself, so there need not be anyone else there. There are also these within-person factors, and they are activity competence, defined as the ability to execute the activity to an expected standard; sense of self, which includes self-perceptions of confidence, satisfaction, self-determination; and preferences, which are the interests or activities that hold meaning or are valued. These within-person factors are influenced by participation and in turn influence future participation. They are important to participation, but they are not participation. The person in the model portrays a general self-regulating process that binds those intrapersonal processes. Self-regulation includes those executive processes that direct and monitor our thinking, emotions, and actions. So these shapes are the core concepts in the framework, but we've also considered how those constructs are related to one another. And these are the arrows in the framework. The family of participation-related constructs is a transactional framework in which we hypothesize a range of transactional exchanges amongst the concepts. Between participation and activity competence are processes of acting and learning. Competence is an outcome of actions, that is, learning skills over time through participation, and it is also a predictor or enabler of future participation. Between sense of self and participation, we hypothesize processes of engaging and perceiving. Sense of self evolves as a result of perceptions of the participation experience. Processes between preferences and participation are choosing and complying. Children choose a preferred activity or comply or cope with the choices made by others based on past experiences or expectations for future participation. Processes between the intrinsic constructs are also important. The individual experiences a sense of competence or not, which colours their sense of self as someone who acts in the world to achieve a goal. Between sense of self and preference is the act of interpreting. The interpretation of past or current experiences in relation to sense of self and competence influences the development of preferences. It's through both the experience and the interpretation of the experience that preferences are formed. The family of participation-related constructs not only describes intrapersonal and person participation processes, but also considers the processes between the environment, the context, and the person. The environment and the context are seen as providing and/or regulating opportunities for participation, and the individual is seen as responding and influencing the context of the environment. So there is a transactional influence, and both the individual and the context are changed. So there are 2 or 3 key points to make here about the distinction between the ICF and the family of participation-related constructs. The first is that participation is separated from the life situation conceptually. This means that participation can be considered in relation to any activity or life situation, according to the cultural or personal circumstances of the individual or group. Second, participation is separated from activity competence conceptually. Activity competence, whether that's capacity, capability, or performance, are all important in their own right, but they're not the same as participation. This fundamental distinction is really important, especially for those people who have complex impairments, who may have severe activity limitations. They can still be supported to participate, and their participation should not be penalised or thought less of because of activity limitations. Third, change is understood to be transactional, as described by those bidirectional arrows. This is consistent with the ICF, but for the family of participation-related constructs, we really highlight and value those transactions as the focus of our interest in terms of intervention. So what does it mean to be goal-directed in relation to participation outcomes? It means that our goals and intent for change need to be focused on improving or changing attendance and involvement in life situations. There is strong evidence in support of the effectiveness of goal-directed interventions in relation to developing skills and ability, that is, activity competence and other motor functions. Although the Novak systematic review referred to here highlights goal-directed training as a green light intervention, there are many other green light interventions that also embed individualised goal setting into their protocols. Indeed, as Margaret Wallen and Brian Hoare say, goal setting is inherently intertwined with many current and evidence-based activity-focused interventions for children with cerebral palsy. So if we know that goal-directed activity-level interventions are effective for improving activity performance, what about participation? Participation goals need to focus on attendance and involvement in required or desired life situations, and remembering that attendance is about being there. So goals can consider the frequency of attending or the range or diversity of activities in which an individual takes place. Involvement is the experience of participating while you're attending. So goals can consider elements of engagement, persistence, perhaps social connection and affect. Setting participation goals then might require more detailed awareness of the lives of children and families, because participation goals will be closely linked to personal, social and culturally determined preferences. So what could participation goals look like for our 6 young people with cerebral palsy? Let's just think about 3 of them. George. George is an infant, so setting goals will be done with parents and caregivers rather than directly with George, although careful consideration of George's preferences and family circumstances is needed when talking about participation goals. The most common life situations for George are at home or with family in the community. He does not currently attend a daycare setting or an early intervention program. For infants in particular, attendance may not be in their control, so this is something to discuss with families. To what extent is it possible for George to be in various life situations? Are there life situations or activities that he could attend that he's not doing so now? Involvement is defined as the experience of participation while attending, which might include affect or emotions. We know he's a socially engaged little boy. Perhaps involvement goals can use this strength to build increasing engagement with objects during daily household tasks. So, some examples. George will participate in daily household activities with his mother. George's mother might set up 1 or 2 daily household tasks each day in ways that allow George to be at the activity. George and his mother can increase the range of situations George takes part in by joining a weekly playgroup. George can be supported to engage with the people, the place, the objects, and the activities in those situations. These are very simple examples, and I'm sure they fit very easily within your usual ways of working when you're focused on supporting young children to build motor skills. The focus here, though, is on being in a variety of situations, and while attended, being supported to be involved, to be connected to the activity and the situation. Participation aims to provide the child with a range of experiences and opportunities. Involvement typically provides opportunity for skill practice, but the primary focus of intent for those supporting the child is involvement. Involvement can include any or all of thinking, feeling, doing, interacting, but not necessarily about having the explicit skills to independently do a task. A child might be involved in a range of elements of an activity or a life situation. What about Ursula, who's 5? She's shy, remember, and she enjoys playing with her sisters. And I've already told you that her family are recent refugees from Somalia to Australia. They've experienced significant hardship over the past few years. Ursula will start school next year, where her parents hope she will start to make friends. At present, the family don't have many community connections. So the life situations for a 5-year-old are focused within the family and daily living activities, learning, playing, culturally determined. And for Ursula, there's cultural determinations that are within her family, but also in her new country of residence. When we think about attendance, 5-year-olds can have some choice over the life situations or activities that they do, and they can be involved in goal setting with the support of parents and others. Frequency or diversity of life situations that Ursula attends could be in focus. And when we think about involvement, that experience of participation, then Ursula's sense of engagement rather than disengagement, involvement rather than exclusion, are really important. So eliciting her sense of this will be needed. Does she have the language for that? Are there behaviours that others who know her well would interpret as evidence of her experience of involvement in various situations? So a participation goal for Ursula might be that she'll take part in a storybook group in her community, that she will attend the program at the local library weekly with her mother and her sisters potentially. Being involved in the group might comprise of her showing interest in favourite stories or attending to the story while it's being read, responding with story-related affect during the telling, sharing books with other children or choosing a book to take home. Again, just a simple example, but what becomes clearer here is the complexity of the idea of involvement. It's easy for me to say Ursula will be involved, but what needs to happen to enable that? Involvement in a range of life situations over time probably contributes to being, becoming, and belonging, important attributes of well-being and health, as well as to varied skill development. What about Morris? Morris is 18, is GMFCS 4, Max 4, and CFCS 3. He's non-verbal, and he uses his personal communication book to chat with others, both familiar and unfamiliar people, if they and he are patient. He loves reading the newspaper, cruising around the shopping centre and sports. He'll be leaving school at the end of the year. When school comes to an end, a whole set of familiar structures shift and change. This is a complex period for every young person. For those with multiple or complex disabilities, it can be a time when their available life situations shrink rather than grow or expand. Goal setting is undertaken with the young person themselves, if at all possible. They may choose or need to have a support person with them during goal setting, as often their ongoing interdependence will impact the opportunities available to them. Of course, planning for the transition from school must begin well before the age of 18 and continues beyond 18. But often, this is the age at which the participation experiences that young people have had in the past really impact their future opportunities. Again, some simple examples of participation goals. Morris wants to get a part-time job. He's asked for help to work out some options. This goal might be supported by his participation in a structured 4-week program aimed at exploring his choices for further training and or workplace learning. Morris also wants to increase his involvement in his local community recreation centre. Currently, he likes to swim, but he doesn't go very often. They do other activities there, but he's found it difficult to work out how to get further involved. So a more specific goal here might be that Morris will negotiate the environmental accommodations that he needs with the Community Recreation Centre to support his desired level of involvement. The work of the young adult and of all of us is to put in place the situations and opportunities that support us to have a good life over time. So when we're thinking about goal setting for participation and the goal is attendance, then some of the aspects that might need to be in focus include things like how often should it happen, how many different activities are done, how much time is spent in a particular situation, and really importantly, what is the pattern? What is the relative balance of participatory attendance across life situations? There are quite a few measures available that will support us to be able to capture some of those goals. But one of the questions that I have for you and for all of us is how much is enough and what is a desirable pattern and how do those patterns shift and change over time? And when the goal is participation involvement, aspects that might need to be in focus or considered is the depth or the intensity of the experience. We might need to think about engaging in something, so the focus or the persistence, or indeed engaging with that interchange or exchange between objects and people. We also need to think about whose perspective is considered when we're thinking about involvement. Now, sadly, there are not so many good measures available for involvement. This is an area for us to continue to work in. And I also have questions here about how does involvement change over time? And again, how much is enough? So we've talked about goals, and let's just briefly talk about some interventions. The other thing that the family participation related constructs does is talk about participation as both means and ends. So we can think about interventions from this perspective. When we think about participation as ends, we mean that interventions may aim to improve participation outcomes through varied means, so that participation, attendance, and involvement are the desired outcome of the intervention. Here's an example. If Melanie attends Scouts, but she prefers to go when the activities are in the hall, the outdoor activities are harder for her. Her participation is strongly influenced by the environment or the context, along with her activity competence, sense of self, preferences, and of course some of her body functions. There are some emerging evidence-based interventions that we could consider to support Melanie and her participation in Scouts as an outcome. They each focus on changing the context and the environment to support improved attendance and involvement. So my first example is Canadian, and it's the Pathways and Resources for Engagement and Participation, PREP, designed and tested by Dana Annaby and her team. PREP aims to increase participation by removing barriers and coaching youth and parents. It's a 12-week intervention summarised by the schematic: make goals, make up a plan, make it happen, measure processes and outcomes, and move forward onto the next goal. Evidence to date is positive, with a demonstrated increased frequency of participation, and most recent publications also demonstrating that young people who improve their participation also have reductions in their impairments, things like lowered anxiety and improved strength. My second example is an environmental context-focused intervention is FitSkills, designed and tested for those aged 13 to 30. FitSkills is a student-mentored community-based exercise program that aims to increase physical fitness and ongoing participation in community physical exercise. There are two key elements: matching of a university student mentor with the adolescent, and then they exercise together at their local gym. This is also a 12-week program. The mentor provides social support. They're not a personal trainer. The pair train together. There is individually tailored training program for the young person with a disability, and then transition planning for the end of peer mentoring component. And there is evidence that this intervention is effective over time. My third example is Jessica Kramer's project TEAM. TEAM stands for Teens Making Environmental and Activity Modifications, and this is from the US. The program was developed with and for young people with intellectual impairments. Project TEAM takes the approach of teaching youth to identify a participation goal, develop a plan to identify barriers and strategies, implement the plan, and check if their plan worked. A goal, plan, do, check approach. And importantly, within this program is an 8-week group training program where 5 key strategies are taught: planning ahead, teaching others about disability, using things differently, doing things differently, and changing spaces. So these 3 examples of interventions were designed to promote participation outcomes in the community by intervening at the transaction between the person and the environment. They did not aim to change the body structures or functions to change participation. And although skills were undoubtedly learned, the focus of skill learning was not on doing the activity itself, but on negotiating the environment. From these and other related examples, some of the effective ingredients to improving participation as ends can be distilled. The first is that they involve individualized, personally meaningful participation goal setting. The intervention occurs in context in the activity settings that are safe, provide learning and support family. Coaching or mentoring is provided, so the therapist coaches the individual or family rather than doing for or doing to, and a peer mentor might work with. There's a solution-focused environmental and/or activity adaptations that are negotiated, and often there's a skilled facilitator in the community. And finally, it's a carefully chosen or tailored multiple strategy approach that's taken in a structured framework. So let's think about participation as means. In this case, we're thinking about participation as a process. And what we mean here is that interventions may aim to use participation and attendance and involvement as the means to other outcomes and future participation. So in this instance, participation, attendance, and involvement is the intervention. When participation, attendance, and involvement are the means, then we use them to influence the child or youth's activity competence, their sense of self, their preferences, their body functions, and they influence their context and environment. And not only that, but prior participation will influence future participation. So what might that look like, participation as means? So the first example is inclusive spaces, really important. Inclusive spaces are based on universal design principles so that they are free of physical barriers, they provide a welcoming atmosphere, they're child-centered, they use friendly approaches to everybody, and furniture, equipment, and other materials are suitable for all children. And that means that any child in the situation can exercise choice and experience engagement. A second way to think about participation as means is to consider immersive environments. These are experiential approaches where opportunities are provided by immersion in real life. They're supportive and they're activity focused, but the settings provide a real opportunity for experiences that involve personal growth, choice, and social interaction. And that over time, these experiences lead the young person to a greater awareness of their own strengths and their sense of self-identity, and a broadened sense of the opportunities open to them. Residential life skills programs are examples. Residential life skills programs are varied. They often focus on a particular type of participation outcome, for example, work preparation or adapted physical activity, or a community mobility program or a community arts program. They may be offered as live-in over several days or weeks, or as day-long programs distributed over time. But the key ingredients of these immersive environments is that they provide a supported program atmosphere with multiple opportunities for social interactions, choice, and personal growth. They're socially mediated. There's a teaching and learning, but they're non-intrusive strategies that aim to support, encourage, and engage youth and children in the experiences over the longer time. There's an intentional fostering of experiences of social belonging, of choice and control, and psychological engagement and meaningful interactions. The outcomes of immersive programs have been shown that youth end up with an awareness of new opportunities, a sense of hope for the future, greater self-determination, and a capacity to select preferred niches and places for themselves to be, and the creation of new goals. So being participation focused means that we are starting with the end in mind. That is, positive participation outcomes for children and youth with cerebral palsy. Optimal participation contributes significantly to health and well-being across the life course. Patterns of participation start very early and influence future patterns of participation. Of course, disruptions can and do occur across the lifespan for all of us, but brief interruptions are one thing. But if a child's experiences over time in multiple contexts do not support their attendance and involvement in life situations, then they become more and more specialised, and they only fit into very particular circumstances, very particular activities. And these participation restrictions can lead to exclusion, isolation, and poor physical and mental health. So if we really want to enable people with cerebral palsy to participate in all the things that they need to, want to, or have to do, then starting with optimising participation, attendance, and involvement may lead to maximised activity competence, a positive sense of self, development of preferences for healthy lifestyle choices, and minimised impairments. So finally, I would say that in the family of the participation-related constructs, the shapes are not as important as the arrows. Understanding the transactions amongst the domains and supporting the processes is really important. As therapists, we're often focused on acting and learning to build competence, but there are many ways to support participation outcomes that need to be considered. Participation is attendance and involvement. Thank you for yours. So, I wonder, Are there ideas here that you can use?
May I take this opportunity to briefly summarize what you said just now?
Yes.
With the permission of all the members here?
Yes, please, ma'am, go ahead.
Thank you. Thank you, Professor Kristen Ims, for an insightful and thought-provoking presentation. Great presentation. As an occupational therapist, I completely see the value of attendance and involvement in assessing outcomes of therapy for any developmental disability, including cerebral palsy. Professor Ames, I think your presentation today helped us to recognize the importance of life situations, context, attendance, and involvement in goal setting. With that in mind, I think we'll be able to, we'll make a conscious effort to incorporate the concepts of FPRC, which is so beautifully presented today. Looking at participation as a means at this point may be a long journey for us, but I'm sure with collaborative and collective effort, we can create those inclusive spaces and experiential learning setups for our children. But we could all focus on participation as an end. Even when working on body structure, we could work with the families and support them in creating opportunities for all our George, Alice, Ursula, and other children to practice the skill across multiple situations and environment. Here, I cannot resist to emphasize the role of functional skills and play have in therapeutic intervention for children with developmental disabilities, and the need to weave in both during our intervention. Friends, I'm sure you will agree with me that it is on such occasions that we miss not being able to listen to the speaker in person. Had that happened, Professor Christine, you would have seen all of us giving you a standing ovation for your presentation. Thank you.
Thank you. That's very kind. It is difficult not to see everybody in the audience, isn't it? Yeah. Thank you for your summing up, Anjali. And I think I agree that it is harder to see how we use participation as means when we're thinking about our therapy situations. But I would also say that because participation is happening every minute of every day, then the children have the opportunity to use participation as means all day, every day. And I think it is how do we help support families and schools and community recreation situations and all those other places that are important, the important spiritual places that we need to be in to actually engage with the children so they have an opportunity to really be part of those situations to the best they can be.
So true. So true. Yes. Let's hope for the best and see that change happening across.
Absolutely.
We have some questions.
Okay.
I think so. Can we take some questions?
Yeah, I'm happy to take a question.
The first question. So the first question that was asked was, do you do accessibility audits? What are the ways you identify barriers to accessibility?
So I think there are often places where children and families would like to be and they cannot be there, even in our well-developed countries, that there are times when that's very difficult. So do I do it? I don't probably spend a lot of time doing accessibility audits in terms of the physical access, but we do look for ensuring that the community settings comply with the requirements of their councils, and that does mean that access needs to be possible for everybody, whether they are using wheeled mobility or not. But I think more one of the things about access is that sometimes a building is accessible, but people don't perceive that it's accessible. So they don't feel like it's accessible, so they don't go. So I think supporting people to understand how to access things that are available is also important.
Thank you. The second question is, what is more important for participation, changing body structure and function or environment?
I think the evidence is really clear that participation is more effectively supported by changing the context and the environment. I think there are times when we are able to make a major change to body structures and functions, and that has either a major negative impact or a major positive impact, but they actually have to be quite big changes to the body to really affect a change in participation.
So
and in actual fact, mostly the barriers to participation are in the environment and the context, not in the body function. So the body function might be what stops the person independently achieving a task or an activity, but that's not the same as participation. Participation is being involved in the situation.
True, very well said. Third question then is, how do you formulate participation goals for a child with CP who lives in an environment with accessibility barriers?
So I think if the barriers there, so I often would see this situation is where it's a really good time to start using the strategies that have been designed in the PrEP program, one of which is to build a participation team around the child and family. And the participation team around the child and family might well be community members who have some influence over the environment's accessibility. There may be some environmental access issues that are very difficult to resolve very quickly, but there usually are workarounds for access. And I think if you cannot access something and it's an important life situation, then that's a real restriction and exclusion. And so I think solving those problems is really an important thing to tackle. So there may be other people in the community to liaise with than only the child and family.
Yeah, thank you. So there are two
question.
Sorry, go ahead.
Asha, I had is, what is the importance of technology in participation? Augmented reality or virtual reality, or even mobile-based apps. So do you think that will improve the participation?
Yes, I do. And I think we're already seeing major improvements in people's connections and connectivity through social media and the internet, and being able to connect with friends and peers through games and so forth. There are also risks there, of course, in terms of sometimes the participation experiences are not positive. So we do have to be mindful of that. The role of technology in solving access problems is also really, really important. So sometimes that's technology within buildings, it might be technology within activities to enable someone to actually achieve the engagement with others in that activity. So yes, I think technology is very important.
And the last question is, are there any outcome measures for participation?
Yes. Yeah, it's interesting. We did one of the systematic reviews I didn't talk about was one about participation measures, and this systematic review ended up being very large. We looked for measures that might be suitable for children of any age up to the age of 18 and for any diagnostic group. And we actually found well over 300 different measures had been used. Unfortunately, most of them didn't measure participation. They measured other things. So there are fewer than that. There are a range of measures that capture attendance, and you can see attendance is quite straightforward in some ways. You can observe somebody attending something or not. That you can ask people, how often do you do something? There are many fewer measures of involvement. So for children, the participation and environment measures for children and youth, so that's Wendy Costa, and the young children's participation and environment measure with Mary Catani are both measures that capture the idea of how often children take part in activities in home, school or community, and also when they are taking part, how involved they are. So that's really a landmark set of measures. We also have been working on a measure called Picture My Participation, which was specifically designed for low resource settings, in that we wanted to have a measure that would elicit what children thought, and also didn't need people to be able to read or to be able to write, to be able to tell you about what was going on. And so it's a picture supported interview that asks about how often and how involved children are in their participation across a range of activities, and also talks to them about what makes it easy and what makes it hard. So you can think about some of those environmental barriers and supports that are there for them. So there are a range of measures available.
There's one more question. Sorry, it just came in.
That's all right.
It says, I guess she is a special educator or means that. Ma'am, in what inclusive education is suitable, like in a country like India, without changing environment and without recruiting special educators?
So I think when we think about inclusive education, two things. First of all, we mean that the children have a right to be in the classroom and are enabled to be in the classroom. And the second is that when they're in the classroom, that there are all the opportunities that we can possibly provide for them to be engaged in the learning activities with their peers are there. And I think that is really complex. And I think again, I apologise for my lack of knowledge of the Indian context, but if it's like there'll be variation, I'm sure. Most countries have some schools that seem better set up than other schools. That's the true here, so I'm assuming it's true everywhere. But that means that some children have more resources available to them, and some children and teachers have very few resources available to them. And I think it's incredibly challenging for a teacher who is supporting children with really complex developmental needs, not only physical ones, sometimes behavioural as well as intellectual. So you have quite a range of issues to be addressing. So how you do that, I think, is by looking at the child and seeing what are the things that child is able to do now, and what are the opportunities that we can provide them repeatedly, because we know that children need repeated exposure that will help them engage with the materials and the learning opportunities that are there.
Thank you so much. Really, thank you.
Dr. Sunanda Reddy is here. She's a developmental pediatrician. So I just, ma'am, you have any comments or questions for Christine?
Actually, good afternoon.
Good
at
afternoon.
the outset, I would like to apologize to Christine and everybody for not being able to join on time due to technical glitches. But I joined just a little after Asha started introducing. And so I've not missed much of this excellent talk. And I should say I thoroughly enjoyed this presentation.
Thank you, Dr. Reddy.
Yeah. I don't have questions, but I just have a couple of personal things to share, because many of us in this field of neurodevelopmental disability know you as somebody whose research has focused on increasing participation of children with disabilities in society. And at a personal level, I was drawn more to your work also because I believe, like you, that participation is both a means and an end. And I love the way you talked about participation as a process. So I think one of your early papers, which actually made me sit up in the course of my work, that I was mistaking attendance for involvement for engagement. And so I think these subtle differences have been brought out very well in your talk, and I must thank you for that. And so the whole question for all of us is, how do we enable participation outcomes, improved participation outcomes? And I think your talk really addressed the issues very well. Thank you very much.
Thank you very much for your feedback.
I have a small question, because when we look at childhood disability, it's managed as a team. There are many members of the team. And how do you, ensure alignment of the team members towards a goal or participation? Because a speech therapist may have a different goal than a occupational therapist, and who has a different goal than a special educator. And an orthopedic surgeon like me has a completely different goal. So how do you align these goals?
How do you do it now?
I know.
So it's easy nowadays because all of us are doing, online consultation and everybody is on a Zoom. So, we have no choice but to be aligned. When we were consulting in different rooms, it didn't happen that much.
No.
It's a transdisciplinary approach. You work from a goal.
Yes, that's right. I think for me, if the goals of the child and the family are participation focused, then the contributions of the team members are relatively obvious. And I think it's there are opportunities for everybody to actually contribute their expertise to the success of a participation goal. And I think that we can all be territorial, can't we? I mean, as disciplines, we can think we have a particular piece that's ours, and we do. That is our particular knowledge and our particular expertise. But I really think that solving the participation problems for children with disability, regardless of their diagnosis, is a team effort and issue. And the broader our community's understanding, and that's our community as professionals as well as our communities in which we live, the broader that understanding is of disability and how the environment and the context, that includes people's attitudes, people's knowledge, people's behaviours, people's actions, as well as how things are built and designed. The more we all know about that, the faster we're going to change society to be more inclusive, more broadly. So I would just say keep meeting on Zoom so you can all be there together.
I think what probably adding a bit to this, I mean, looking at how family-centered are we and how much are we focusing on the strengths of a child so that the child is finally then engaged into the society is what is something which all of us need to be on the same platform for that. So I think to answer your question, Taral, that the goals might be different for all of us, but eventually the end goal has to be how independent this child is functionally and how engaged is he in society. And once that remains, then the, so to say, sub goals of all the professionals might be different, or the way to reach to that point.
The sub goals. I think that's the right phrase, Anjali. That that it's how you thread those goals together, isn't it? And it's also how obvious it is to the child and family that the goals belong together. That needs to be obvious.
I think if all the professionals they feel if all common understanding, then everybody's role is fixed. So all have to act accordingly to reach the common goal.
Yes,
absolutely.
Understanding among the our experts is very important. Common understanding.
Dr. Shashikala,
could I add something here?
Yeah, ma'am.
Basically, I'm talking from my experience of working in the community, and participation is very important for us, and specialists are not many. So what we see here is definitely what Asha mentioned, the transdisciplinary approach is important. But when we involve the parents from the beginning in the goal setting for younger children, I think it becomes much easier for us when we are providing family-centered services for children with special needs and the goals are set with the parents. We know that these are the requirements for the parents and we shall work on them. And accordingly, the professionals, we interact among ourselves, and not every professional has to enter the community, but then the key professional who's facilitating this work, acting as a bridge between the community and the expert group, actually can go along with the goal setting step by step next. So that is how we've been doing. For instance, Dr. Nagda's question, how do we do? Because in the goal setting, we know that there is a parent who's very interested in the orthopedic aspect or in something else like control of epilepsies. So we do have to create a team, and like Dr. Christine mentioned, we need to connect either through Zoom or telephone calls or referrals that we do in the traditional way. But I think the goal setting with families is very crucial there to ensure that the transdisciplinary work goes on.
I think that's really a really important point, Dr. Reddy. I think that the other point I was trying to make in my talk was this idea of being focused on participation has to be central for families and children from the very beginning, because I think it is really, I talked about my own experiences, that it's really easy for families to become what's the word, very medically focused, very fixing it focused. And I think that the more that families are able to see that this child in our family, in our community, will need to grow and develop and participate to whatever extent we can possibly support them to do throughout their life, and that some things can be fixed and we must do that. But many things maybe can't. And we still need to be able to grow and develop, and growing and developing and being engaged in a part of your community doesn't mean you have to be able to do all of the normal tasks that everybody otherwise expects. You don't have to.
Shashikala madam, would you like to give your comment?
Yeah. Sorry, I joined late. Can you hear me, Asha?
Yes, we can
Yes.
hear you.
Yes.
I was supposed to inaugurate the webinar. For some personal reason, I joined. I thoroughly enjoyed the talk, Christine. Knew you on mails, but it was a pleasure hearing you. I just had one question. These are some new concepts. How do families take these new concepts? How supportive are families? Because we find families far too often are still stuck at the structure level at the best activities. What do you do to move them to the participation level?
It's such a good question. When I talk with parents of older children, they say, "Oh, thank you. It's time," because they're just really ready for it. But we talk with parents who are have children who are newly diagnosed, so much earlier in their journeys. Actually, we talk to them straight away about this idea of being, becoming, and belonging as a way of thinking about development, rather than walking and talking and being able to go to the toilet on your own. So, so I think this sort of way of talking around that is strengths-based and future-focused starts really, really early. So I think it's actually when you start the conversation, it makes it either harder or easier. I think there's a period of time in many families' journeys in disability where they really are, they become quite used to how we talk. We use our language of medicine or of therapy with them, and they start to kind of tell us that they have goals around, can I please move my child's arms be stronger or whatever, as opposed to goals that are, I really like my child to be involved in a particular set of situations or activities. So I think we help them learn that by our conversations and what we pay attention to and focus on. I think we lost.
What I have realized it, with the development of the child, the ICF priorities for parents change. For example, participation is rather a priority for parents of older children. So young parents are still, they want to see how best they can normalize their child. So I think maybe, as you said, we start very early, as participation is our ultimate goal, and that should make them accept it.
And I think it isn't an ultimate goal. I think it's a goal for today, no matter how old the child is. And I think if it's very important that we don't end up having parents feel that they have to be working all the time for the because they lose sight of the fact that being a parent and doing the usual things that a parent does with children is actually the very best thing that they can be doing. And so I think supporting that, optimizing that for parents and families when there are complexities related to disability is really, they're really living complicated lives, these families. So helping them to find a usual way, a usual pace for them, and really recognizing and valuing the opportunities for involvement of their child in that family life and in their community life, whatever that is, I think is really, really important.
Maybe it makes sense to shift participation as the first domain for parents and put the structure in the land when we talk about ICF to them. That would be, it may drive home the point.
Yeah, so Peter Rosenbaum and myself and some colleagues in Canada and Australia have been working with a group of parents to design a program called Envisage, which is for parents new to the diagnosis of childhood disability. And we're just about at the end of our first open evaluation of it. And it's a 5-week online module where we designed it with parents. So they've helped us all the way along. And it really is addressing some of those core ideas around the ICF, around the F words in childhood disability, around being, becoming and belonging as a focus for development rather than the normal kind of achieving my milestones, about how parents need to look after themselves and how they can communicate and collaborate and connect within their communities and through their therapy services. And I think it's exactly what we're doing, Dr. Shashkala. It was actually looking at how do we set up families in this way from the very beginning, in a way of thinking that is about embedding this child into real life.
True. Yeah. Our Cerebral Palsy Day theme is My Efforts. I think we'll take it upon in a big way to stress on the importance of participating to parents. So,
yeah, and it's not to say we shouldn't be doing all the other things. We still need the orthopedic surgeons, and we still need to practice our skills, and we still need all those other pieces. It's really a shifting the perspective a little. Yeah.
Thank you.
Thank you.
So we ask Saktidas sir to thank.
Okay. Thank you. Now the webinar has come to an end, and it is customary to say a vote of thanks. And I think it is an honor for me to convey the vote of thanks. Respected our President, Mr. K.D. Mallikarjunji, our Board of Directors, Madam Dr. Sasikala, Dr. Johari is there also, and all Asa, our Vice President, and all the members of the technical team, and our expert today, Professor Christine. From my bottom of my heart, I convey my sincere thanks to all of you for making this webinar a success. And I would like to express my gratitude to Professor Christine for making an excellent presentation and making the webinar a grand success. My words are not enough. And she has spoken in detail about the goal-directed interventions and participants in the community and the family in detail. It must have a benefit to all our participants in India. Hope ultimately the knowledge what you have transferred will be useful to all the participants today in the seminar, and ultimately the benefit will go to our children with disability. So, or development disability, or cerebral palsy in special. So thank you very much, Professor Christine. And also I convey my thanks to our moderators, Dr. Sunanda Reddy, and also Dr. Anjali for moderating this session so well. And it was a pleasure that the webinar came to reality, and due to your well planned moderation, and also the expert comments by Dr. Sunanda Reddy at the end, because she's having a practical experience in the field. Thank you very much, madam, for your joining this webinar.
My pleasure, sir. Actually, I have to apologize that I just missed the beginning, but it was very
No,
good.
you are there. I saw you after 2-3 minutes. You have joined there in the program. Thank you very much, madam. And also, I would like to thank our I can say our medical web technical team, led by Dr. Taral, Dr. Asa, for coordinating so well. They have given so much of time. Dr. Minakhi and Sanket, Madhavi, coordinating, giving the time. We have all the meetings, all preparatory meetings, everything they have done. They have devoted so much of time. So I have no words to thank them all. They have collected a recording also. If in any problem there also, it can be also passed through the YouTube. So for this technical help, I am really thankful to all of you, the team. So due to your help, it has become possible. And in the last, I want to thank our president, who is guiding us time to time, joining with all the he's going through the academic activity of the this association, and also selecting and also communicating with the experts and keeping in and guiding us so well. And that due to his guidance, this all the program going one by one. Thank you, sir, for very much for your participation and interest in the this our association. Thank you very much, sir. Last, I want to thank you all and all the participants, and thank you all again once again all. Thank you very much.
Thank you.
Thank you, Shaktidas sir,
thank
for
you.
kind good words. See, Professor Christine Emin, we have received so many wonderful comments on your talk. That one comment is excellent talk. Thank you very much from Truptin Karge, and some appreciative comments. This is just beautiful. In the search for giving the best for the child, parents should not lose focus on enjoying the journey. Many such wonderful comments we received. Thank you very much, Professor Christine and our Dr. Anjali Joshi for her wonderful moderating, summing up the program. Thank you very much. With all our inspiration from our board of directors and our cooperation from our Dr. Shakti Das, plus Asha Chetnis, Dr. Taral Nagda, Dr. Sanket, Dr. Madhavi, all of them are working very hard to make all these webinars successful. And we are going to have more academic fees. We assure you that with all fine, good quality academic webinars we will be organizing in future. Thank you, Professor Christine. Thank you, sir.
So before we
Can
end,
Can I say thank you?
Absolutely. So
You've given me a really wonderful opportunity to talk, and I really, really feel very honoured to have been asked, and also to have been able to have a conversation with such distinguished experts. So thank you for that opportunity.
So at the end, I would say how a talk changes mindset of people. So next week we have a webinar. This is on Saturday, but it's going to be at 7 p.m. because our participants are from the United States of America and in a different time zone. So John Davids and Lisa Wagner from USA and our own past president, Dr. Purohit, they all will be covering different aspects of upper limb cerebral palsy. So I want everyone to be in good attendance and involvement. So that means good participation. And, please be there.
You passed the quick quiz.
So shall we end?
Yes, sir.
Thank
yes,
you.
sir. Thank you all.
Thank you all.
Thank you, Taral.
Thank you, sir.